TCM channel. Today we will be presenting a case with alleged history of ingestion of Odallum poison. Understand, sir? Sir, and I got a short history from the ENT that a girl has been brought with alleged history of accidental ingestion of Odallum poison. So I went to my and I did my initial 10-second assessment. Patient is conscious, oriented, and was completely able to respond to my commands. So immediately I started my parallel survey of primary survey. Airway is patent, no oral secretions, no tongue fall, cervical spine movements, everything was within normal limit. Then assessed the breathing air entry bilaterally equal, saturation maintaining in 99% in room air with a respiratory rate of only 16 breaths per minute. Then I went to immediately started the circulation. I immediately auscultated palpated the pulse. Pulse was irregular, but in the bradycardic. So immediately I connected the chest leads also. In chest leads, the heart rate was showing around 45 with varying heart blocks. Intermittently it is sinus pause, and sometimes with a normal PR interval, but sometimes there is sinus pause. Sometimes even a type 2 Wengi back phenomena is also there. To a consecutive gradual PR prolongation following MS, then again becoming remain normal.
Initially, the same thing I've told you before. No, initially once you're saying, just give us a time frame of when this happened, so that once coming to the clinical presentation, we have some kind of correlation. If it is like 10 minutes back or 6 hours back or 12 hours back, it makes a difference. No,
referred from an hospital.
And also, if, in this case, if you can say what part of the plan, it will be good at that point.
This patient actually came to our hospital on next day, but the patient was found to be this bradycardic and was managed in an outside hospital on day before yesterday itself. After around 6 hours post consumption, child developed multiple episodes of vomiting, following which child was taken to a local hospital. She gave this history and they suspected also, and she was gradually decrease in heart rate, and she was under the monitoring. Since now her heart rate has come down below 50, they have immediately referred to us. Our monitor was showing some varying degree heart blocks were there, but her BP was maintaining, and no features of no bradycardia, no other symptomatic features were there, no altered sensorium, no loss of GCS, no hypertension, no other features, no chest pain.
Why these things are important?
Because as per irrespective of the etiology, we follow the HA guidelines. So a patient, if he is bradycardic, whether to intervene or not, it's based on whether the patient is symptomatic or not. Currently the patient is asymptomatic bradycardia, so we need to observe the patient with the continuous cardiac
Which are the symptoms that you will consider? Can you just tell?
Altered mental status, hypotension, any chest pain or any cardiac failure features, anything has been there, and you have to intervene, sir.
Okay.
And so this patient, we didn't have any features.
Any history of syncope?
History of syncope also can be taken, but patient if
no, I am asking whether this patient had
no, sir, no. As from the history, there was a syncope.
Okay.
Since she was hemodynamically stable, so I immediately asked for an VBG just to get that, because our VBG has electrolytes, so that to get a point of care electrolyte, I asked for an electrolyte at that time. Then I immediately went to the
What electrolytes are you suspecting?
because in hyperkalemia conditions we can get like that. Electrolytes we asked. Then I went to the disability part. GCS was 15/15. Pupils were around 3 mm bilateral but reactive, and GRBS was also normal limit 108 milligrams per deciliter, and peripheries were warm. She was covered with a blanket. So our electrolytes came, initial electrolytes, but it was in the normal limit around 4.5 milliequivalents of potassium. Sodium was also within normal limit. Calcium, it was around 1.01 ionized calcium is there in that. It was also within the normal limits. Other acid-base patterns, since it's a VBG assessed, but it was also within normal limit with a normal lactate. So immediately went for the secondary survey. Since this varying heart block is there, we don't know the etiology, so we sent for a set of cardiac enzymes also. I asked there. Then I went.
You have the history. No? You want a cardiac enzyme here?
Actually, we don't need, sir. But usually we go ahead with in secondary survey only in the history properly. Okay. For in case it's a clear cut, then outside history they are suspecting a Odallum. then we don't need a cardiac enzyme.
You can, whenever in a toxin or a toxicology case, you can send cardiac enzyme
Yes.
when it can cause a direct effect onto the heart, like myocarditis.
Myocarditis.
You can send that, but will cerebral odallum cause myocarditis?
No, sir, because it's a presumption that child might have eaten cerebrum odallum and causing this bradycardia.
Okay.
But as an ED physician, to rule out, she is not having any other issues only.
Whenever you see an arrhythmia, the first thing that you have to keep in mind is an acute coronary syndrome involving the myocarditis. Some myocarditis. This will be a differential that means some ECG abnormality. Whatever be this, any arrhythmia, brady or tachyarrhythmia, you have to see. But here the reason would be for
entirely different.
it is not a first investigation that you need to send for this patient. Unless and until you are not getting any history, there is no history of any ingestion or anything, definitely you can send. But otherwise, maybe you can wait and send.
So I immediately went to the secondary survey. No history of any signs.
So the most important thing, what you notice, you have taken a continuous ECG monitoring. In that, the child had varying heart blocks. So somebody is presenting with varying heart block with this background history. What was the heart rate range between?
Between 45 and 50, sir. Between
45 and 50. Right now, the patient is asymptomatic. We need to have any backup at this point of time.
Sure, sir. Two backups we require. One is medically, if the patient develops further bradycardia or symptoms, we have to give an attempt of atropine. So we have in vial as well as in ampule, sir.
Have you put an IV line?
Yeah, So
an IV line has been secured. Atropine has to be made available. Dose of atropine.
Usually we have in a vial we will get in 0.5 mg, or an ampule we will get in 1 mg 1 ml.
Okay.
So usually we get the vial, so we will 0.5 mg in 1 ml, we will get it ready, sir. Whenever required we can directly push it, followed by normal saline can be given. And we have if first symptoms persist, we will have to repeat it in every 3 to 5 minutes, sir, because the T half is hardly 3 minutes.
Okay.
Next important thing is that we should make sure that if the patient develops any, we will have to go, if the atropine fails, if the child is not responding to atropine, then we will have to transcutaneously pace this patient in ED. So with the pacing, defibrillator should be available, pacing pads with chest monitoring should be connected. Pardon, sir? Up to 3 mg. Up to 3 mg we can.
3 doses in 5 centers.
So again, transcutaneous pads with the direct pacing possibility should be made available and connected.
Can you just brief how will you connect a defibrillator into a pacemaker?
Sir, usually some defibrillator will have the pacing option itself.
That is the first thing. The defibrillator should have that facility. All the defibrillator will have the defibrillation and sometimes AED mode. These are the two things that will be usually available defibrillator. Specifically, you have to ask for a defibrillator with the pacing facility. That is number one.
So then we should require a pacing paddles. It's not that the simple paddles. These are paddles with which we have to specifically ask.
AED paddles.
AED paddles.
Same that of AED paddles.
Then we have to connect it one in the below the right clavicle and one in the fifth intercostal space in the left axillary area, and we will have to connect it into pacing mode. So if we want to pace the mode, then we should go ahead with the consent, and we will have to give some amount of procedural sedation also, because it's an electric impulse again generating. It will be a painful procedure. So we will have to consider for a procedural sedation also.
Which drug you will select?
It's a small dose of even half the dose of midazolam along with ketamine can be tried, because child is in bradycardia. So ketamine would be very helpful. Then pacing, we have to put in pacing mode. Usually if we want to start pacing after a procedural sedation, usually first we will have to set the rate of 60, then we will have to start the usually they will start, but if the child becomes even symptomatically better at a 50 rate also, we can go with 50.
See, backup rates always you can keep it as 40. So whenever the rate is going down below 40, only the machine need to do the analysis and need to give the external pacing. So you can keep it as backup pacing as 40. Maybe initially you can just see and increase the heart rate and see whether the pacemaker is functioning or not, but otherwise the backup rate should be 40, because this child is already having a heart rate between 40 to 50. If you keep a rate of 60, every time this thing will be delivered, so that is not needed. Then what are the amplitude, all those things, sensitivity?
Then we will have to increase the amplitude with the 10 milliampere. We will have to gradually increase. So whenever the pacemaker is delivering, we can see the monitor when straight line will be there, and usually the rhythm produced by the intrinsic myocardial activity will also be visible. So we will have to gradually increase the milliamperes 10 20, and we, at a particular time we will get a capture beat where the electrical impulse delivered by the pacemaker will be given by a straight line and followed by a white QRS will be there. So it means that capture beat is there. Ideally we will keep a 10 milliampere above the capture beat, and we will be rate that as is, sir, if you want to keep a 40 we can set the rate, and with that capture beat we can continue. But it's only a temporary solution. We will have to go ahead with the transjugular pacing and shift the patient to a cath lab and do a transjugular pacing.
So sometimes you have connected to the external pacing device. Okay, the machine is not delivering. So which are the possibilities? Maybe transjugular or maybe transcutaneous also. They are telling that it is not capturing. You are increasing the amplitude and seeing the machine is not capturing. So what could be the possibilities at that point of time? Not for this patient alone, any patient. You have a lot of patients. Maybe you will be having a patient with sepsis, somebody with sepsis, severe acidosis, you have intubated, and suddenly she has gone for a bradycardia, then complete heart block. You want to put a TPA at that point of time. They are telling the machine is not pacing. The machine is not. What are the possibilities that you need to consider at that point of time?
Paddles position, paddles attachment,
Okay.
connection.
So all the
is
mechanical
wiring.
parts you have cleared. Okay. The lead is in the position. If it is in the transjugular one, it is in the base of the RV. It is in the base of the RV. You are confirming it either with your echo or your fluoroscopy, whichever be the method. You are confirming it is in the position. The machine is functioning. The leads, everything is functioning. But what will be the intrinsic problems that can cause not capturing the external beat, external pacemaker beat? That is very common for our patients. Hyperkalemia,
Acidosis.
severe acidosis. So these are the two important things. Even if we feel that the position, everything is right, when acidosis is there, hyperkalemia is there, it is very difficult for us to capture that beat. So that is very common for a maintenance hemodialysis patient who is coming with an MI with this thing, complete heart block. When you are planning to put TPA, this will be one of the problems that we all face. So we have to give a good dose of bicarbonate, acidosis need to be corrected, and hyperkalemia need to be corrected. So that is one point that you need to consider. Okay.
So continuing the secondary survey, the signs and symptoms where the child developed multiple episodes of nausea and followed by vomiting was there, but no other history of diarrhea or abdominal pain was there, following which in view of persistent vomiting child was taken to a local hospital, where the doctor, when cross-examined, child gives that around 6 hours back the child has consumed something like a mango, and it was in a coastal region where possibility of an Odallum ingestion is common. So the doctor there suspects that possibility the child might have accidentally ingested an Odallum, and she was under observation because when the doctor observed, the child was little lethargic and child was having bradycardia at that time itself, and she was under observation, but progressively the child heart rate was progressively coming down, and that's why by next day child has been referred to our hospital.
Which part of the plan?
Child gives that she has eaten the entire soft fibrous part, and she has bitten the kernel part also. So we don't know whether she has ingested the entire kernel part or not. She has given the his history that she has bited the kernel area also.
Why that history is important?
Because if it is a case of Odallum poisoning, then kernel is the most lethal, most toxic in area. Cerebrin is the lethal principal compound that causes this problem. So the cerebrin, it is most concentrated in the kernel area. In fibrous area also some amount is there, but to be lethal, say that it is lethal if you are eating around half or full of one kernel, means it is a very lethal dose. That's why it's important.
How does it affect?
Usually cerebrin is just like a glycoside. It actually inhibits the sodium potassium pump. As a result, the intracellular calcium ion concentration increases and extracellular potassium concentration increases. This increased intracellular calcium will cause three major things. One, autonomicity will increase, and increased vagal tone will be there, and hyperkalemia. These are the three issues that this can produce, and as a result varying heart blocks can be there, and child can develop various arrhythmia, and the most common arrhythmia is that the child will be developing ventricular ectopics followed by bradycardia, and various level of atrial tachycardias can also be there.
Is there any possibility of neurological symptoms?
Neurological symptoms, actually, possibility is that child can develop confusion, probably because of vomiting and dyselectrolemia one issue, and sometimes some books gives a possibility of pupillary dilatation, but extract mechanism we are not sure, sir. Maybe some compounds present along with this, but it's not so clear-cut symptom that the patient should have a dilated pupil.
Any neuromuscular weakness? And
Because of this associated hyperkalemia, patient can develop the muscle weakness and gastric paralysis, everything is possible. Hyperkalemic periodic paralysis is also there. So that's the mechanism of action of this issue. Then coming to then that was the event, and there is no other past history of any associate relevant past history or any medical history, not on any drugs, sir. And event also I have explained. Then I did a acute head to foot examination, which was almost normal. I mean, no pallor, icterus, cyanosis, no clubbing or lymphadenopathy. Patient is right now conscious oriented, and cranial nerves examinations were within normal limit. Other CNS, higher mental functions, motor and sensory system, everything was within limit with the full grade of power and sensory examination. And chest examination was again air entries maintaining bilateral equal, maintaining a normal saturation, no tachypnea. Upper abdomen was also soft, right now non-tender. After coming to our hospital, there was no more episodes of nausea or vomiting, and other head to foot examinations were also within normal limit.
Local hospital, did they attempt a bowel wash?
Yes, sir. They have given one bowel wash, but it was done around 6-7 hours after this injection. No, it is ideally we don't follow such a thing, sir. If it is presenting within 1 hour only, we used 1 or 2 hours only, we go ahead with the stomach wash followed by. If it is a Odallum poisoning, then activated charcoal is not indicated. Only stomach wash if we can try, sir.
Okay. So this patient is in front of him.
Yes.
Now you have got a history of cerebral Odallum.
Yes,
Okay,
sir.
some consumption is there. Suppose here without any history, somebody is with bradycardia. Management part is almost the same. So what are the other possibilities that you need to consider?
If the patient is taking any medications, then we should clearly suspect a possibility of any beta blocker toxicities, anything is there, any calcium channel blockers, any toxicity can also present like this. And if otherwise any early history of any ingestion, like just like the cerebrum Odallum, other than that there is a list of plants that can cause like this. I will just tell some digitalis purpurae, Nerium oleander, Differential perviana, Convallaria majalis, Urginia maritima, Staphylococcus gratus, Apocainum cannabinum, Coriander seri. And one another thing is the rubber well plant. Actually, that's a reported case in India itself, where Ayurvedic medicines were, it was produced from the plant gulwell. But there is another plant very similar to looking like gulwell, that was a rubber well plant. And following which accidentally they have mixed this rubber well plant, and patient succumb into severe arrhythmias. And even one particular type of toad, similar to frog, toad can also poison, lead to glycoside like.
Here you have to consider more into toxicological possibilities. As a young girl who is coming with unknown history, you have to always think in terms of that. Any structural heart disease or anything, myocarditis sort of a thing can present like this?
Sir, myocarditis can again produce bradycardia or tachycardia, sir. So if there is any associated past history of viral infections, everything.
But it's most common now.
COVID sequelae, and then we have to think of that also.
So COVID, there are case reports, the patients been presenting just with myocarditis. Nothing else, they are presented with myocarditis. So that is again one consideration that you need to keep. So primarily when we have a history, it is well and good. But whenever you don't have a history, you have to go behind why this child is having this myocarditis. So what happened to what was the treatment given to this child?
Sir, treatment for this child first.
So what's most common arrhythmia found
Odallum ventricular ectopics is the most common presentation, followed by bradycardia will be there, or atrial tachycardias can also be there, sir, with the blocks, various AV blocks with the atrial tachycardias too is also seen, sir. Then among drugs, one important thing we should keep is possibility of digoxin toxicity also, other than beta block.
So digoxin toxicity, then your ECG should be having that
digoxin features like there will be a coving of the ST segment will be also
reverse tick sign, all those things
can
has
also
to be there. Salvador sign, all those things has to be there. So that is equal to digoxin. So how will you manage now?
Management is first and foremost, again, first our ABCD has to be taken care of, and following which, a second important thing is that we have to have a proper cardiac monitoring and a backup of, just like we have mentioned, atropine and because cardiac arrest, if any issues occurs, it is probably because 99% because of cardiac arrhythmias rather than because of hyperkalemia and all. So we should be ready to manage the arrhythmias. So we should be have the pacing options, and along with the atropine drugs should be there. And a third important thing is that if the patient is having any electrolyte issues, like patient is having hypomagnesemia, hypokalemia, that electrolyte issues should be corrected. If the patient is having associated any calcium if they, for example, management of hyperkalemia, associated hyperkalemia is there, giving calcium gluconate should be very cautious. There are two set of studies, school of studies. In European studies, they are allowing us to give calcium gluconate under supervision, but in our other research, like up-to-date websites and all, they are not recommending use of calcium gluconate.
Hyperkalemia management, again, as you said, it is a very in digoxin toxicity. They have nothing mentioned regarding cerebral odallum. Whenever there is a digoxin toxicity, already there is an intracellular excess in intracellular calcium.
Yes,
so when you give excess calcium, it can sometimes produce harm and cause ventricular arrhythmia. That was the previous school of thought, but there were some case reports. But after that, what they found that if you really wanted to give calcium gluconate for maybe for hypocalcemia, there is intracellular calcium is high, externally there can be calcium can be low, you can give calcium gluconate but with caution. The problem is that this patient can go for a ventricular arrhythmias. That is the problem. So you have to be very cautious in giving, and you should have definitely have backup. So what will be the definitive treatment for hyperkalemia in such scenarios?
Then the use of digifab comes, sir. Digifab is an actually antidote for digoxin, but it can be used in severe Odallum toxicity also. It's an antibody fragments which binds with the remaining digoxin compounds, and actually it will be eliminated by the renal function. Usually in availability of in India is still questionable. Usually we get in one vial 40 mg digifab is available, and it can neutralize 0.5 mg of digoxin.
Okay.
And one more thing is that we should properly hydrate the patient for the elimination by the renal function. So hydration should also
glucose
be taken
insulin.
care of. GI bolus can also be again tried for hyperkalemia. Hyperkalemia, other managements can be tried, like salbutamol or giving in GI.
We are not much concerned regarding hyperkalemia. Arrhythmias are the most common one, but hyperkalemia definitely you see you have to correct it.
So just be cautious about giving the calcium gluconate or calcium chloride. Otherwise, other anti-hyperkalemic measures can be tried, giving K-bend sachets, everything.
Okay, how is the child now?
Yeah, actually, child was observed through entire period. We observed for the 48 hours. Child was asymptomatic. Her heart rate, intrinsic heart rate improved by herself, and she currently we discharged her yesterday evening in under follow.
Okay, fine.
Okay, sir.
Thank you.
Thank you.